All right, you are all set, Lauren. See if that
I'll open up my
works.
presentation, everybody.
Perfect.
Okay, so this is our discussion here about breast cancer awareness and breast health. My name is Lauren O'Connor. I am a family nurse practitioner in the high-risk breast clinic at Duly Health and Care. And like I said before, I thank you so much for taking time out of your Monday evening to talk with me about breast cancer awareness. And I'm sure all of you are coming to tonight's conversation with varying knowledge about breast health and breast cancer, and probably some questions to kind of right off the bat. So in order to get through this entire recording, all kind of at one time and allow the recording to end, I just ask that you please write down your questions or save them for the end, and then we will be able to go over them together. Does that sound fair, everybody? It's okay. All right, so let me go here. Okay, so I'm a member of the high-risk breast clinic team at Duly, and we're a team of clinicians whose job is to help you be proactive about your own breast health. The patients who come to our clinic are at high risk for developing breast cancer, whether it be due to their own history or their family history. And we offer individualized ways to go about making sure that they get the most screening and assessment that we possibly can provide a person, knowing that they're at high risk. So it's a little dry, ladies, bear with me, but I do want to go over discussing a few key points before we get too far in depth in talking about breast cancer and breast health. And I think that that just helps give everybody a chance to understand kind of what we're all talking about and be on the same page. So for starters, what is cancer? Cancer is an uncontrolled growth of cells. So the cells in our body are very smart and orderly about how they grow and divide and replicate. And once they get too old or damaged, they die and are removed. And that's something that our bodies do billions of times a day, week, month. Cancer is caused when abnormal or damaged cells do not die like they're supposed to, but instead grow and replicate. And this kind of change in how cells normally behave is caused by genetic mutations. And that could be a mutation that is inherited or a mutation that's caused by something that is triggered by the environment in our environment. Over time, cancer cells that grow and replicate form a mass called a primary tumor, and that's a tumor that's in a localized area in one particular spot. Invasive breast cancer is, by definition, a cancer that spreads from one area of the breast, such as the milk duct or a lobule, into other areas of the breast or into lymph nodes nearby. Metastasis is when cancer cells that were in a nice little localized area spread. They break off and they travel to somewhere else in the body and they settle down and they continue to grow there. Okay. Let's see here. And two more really important definitions are benign versus malignant. A benign tumor is a growth of abnormal cells, but they do not spread to other parts of the body and they are not inherently dangerous. However, they may need to be removed or treated. Sometimes they can mask malignancies. Sometimes they can cause pain or disruption, but ultimately, by definition, they do not spread. Unlike malignant cells, which cancer cells fall under this category. They are dangerous to your health, they grow rapidly and can break off and spread to other parts of the body where they can grow there too. Let's see here. So I like this little diagram. This is a little cross-section of what the breast looks like under the skin. You see your little chest wall, that's that little red vertical area. You see that little tube, that is a milk duct. And then these little kind of oval pink areas are your lobules, your lobes of your breast. And the lobules are the little circle things inside that make up a breast lobe. And that's where milk is produced. Typically, malignant cells originate in a milk duct or in a lobule. That's usually where we see breast cancer start. Okay. Why do we care about breast cancer? Well, it is the second leading cause of cancer in women in the United States. Each year, about 255,000 cases of breast cancer are diagnosed in women and about 2,300 in men. We tend to overlook men, but they do get breast cancer as well. The average woman in the United States has a 13% risk of developing breast cancer in her lifetime. So that's over the course of however long she lives, she has a 13% chance, and that's average. And despite all of our advances in breast cancer detection and treatment, still about 42,000 women and 500 men in the US die each year from breast cancer. Breast cancer, I'm going to talk about risk factors in a little bit, but it tends to increase as we get older. The median age of diagnosis, at diagnosis of breast cancer is 62. So this is predominantly something that affects people as we enter our later years of life. So I like to talk about risk factors, whether it be risk factors in heart disease or cancer or pretty much anything else that can affect a person. There are always going to be non-modifiable risk factors. Those are things that we can't change about ourselves. And then there are modifiable risk factors, which are risk factors that we have some control over. So in breast cancer, the non-modifiable risk factors I've listed on the left. Age, we just talked about that a little. The older you get, the higher your risk is of developing breast cancer. Height is a weird one. If you are taller than average, you are at increased risk. Certain ethnic groups have more risk for developing breast cancer. Reproductive history is something that I talk a lot about with my patients. If you are younger than average when you start puberty, as well as if you are older than average when you hit menopause, you have more years of menstrual cycles and estrogen coursing through your body. And estrogen is a causative factor in breast cancer. So those women are at a higher risk than average. Breast density, which we're going to talk about in a little bit. Personal history of breast cancer, you have a risk of developing a recurrence. Family history of breast cancer, ovarian, and some other cancers will elevate your risk. A few of these other things are much more rare. Chest wall radiation history. So if you've had cancer in the past where you've had radiation to your chest, you are at risk for developing breast cancer throughout your life. DES exposure is something that we talked about quite a bit in the past several decades. This hasn't been used in pregnant women in several decades. So it's less of a risk now than it used to be in the past, but certainly some of our patients have had DES exposure during their lifetime. And then having certain benign breast conditions. Remember, ladies, we talked about what benign, like what that means, but just by having that in your past may put you at higher risk for developing breast cancer in the future. So those are the non-modifiable risk factors, things that we have no control over, but there are plenty of risk factors that we do have control over, including your weight. Obesity increases risk because it also increases estrogen in your body. Activity level, tobacco use, diet, all those things that our healthcare providers tell us that we should be watching and making good decisions about. By doing so, you're also decreasing your risk of developing breast cancer. Moderate consumption of alcohol, more than 7 servings a week will increase your risk. Age at first pregnancy. So some people would argue that this is not really a modifiable risk factor for some people, but the American Cancer Society says that it is. So if you are over the age of 30 or if you never have children, it does increase your risk. And this really has to do with, again, those menstrual cycles and estrogen that put you at slightly higher risk. History of breastfeeding actually decreases your risk. It's a protective factor is what we call it. And then hormone therapy, such as hormone replacement therapy after menopause, will elevate your risk somewhat. So in my clinic, I talk in great detail with my patients about being self-aware. Breast self-examinations is what people immediately jump to in their minds. And definitely that is important. And we're going to talk about that. But knowing what is normal for you and your body is really important, because the vast majority of abnormalities in a woman's breast are actually discovered by herself. So it's important to know what's normal for you. Breast self-examinations are recommended monthly to detect changes as early as possible. For somebody who is not having menstrual cycles, you can just pick a day that works for you, whether it be the first of the month, maybe the date of your birth, if that's easy to remember. I have a very sweet patient who every month gives her dog heartworm medication. And so she remembers that when she gives her dog the heartworm medication, that is the day that she does her breast self-check. So really, it's just a matter of what works best with your lifestyle. If you're having menstrual cycles still, it is recommended to aim for days 5 to 6 of your cycle, because that is when your breasts are their least lumpy bumpy. So what does a breast self-examination, what should it contain? I like to think of it in 3 different categories. Looking in front of the mirror with your hands on your hips, and then raise your hands in the air and look for any changes or things that stick out as odd for you, whether it be color changes, texture changes, or if the breast doesn't raise when you elevate your arms quite like it normally does. In the shower with soapy fingers, you can actually do a really great breast exam, and then lying down. When we're doing our breast examinations, we are looking for lumps, bumps, anything under the skin that is not normally there, particularly things that are immobile. Something that maybe feels like a frozen pea under the skin, or a pencil eraser, or a BB. But what is particular about it is it won't move if you try to kind of, bring it back and forth. Skin texture changes, anything rough or bumpy, similar to the peel of an orange or a lemon. Skin color changes, anything red or brown. Nipple discharge can be very frightening for people who are not, lactating. We get most concerned about nipple discharge that is bloody, red or brown, or clear, or maybe even looks like apple juice. And dimpling of the skin, or the skin kind of pulling into the body from the breast. Dimples are really, really cute on babies' cheeks, not quite as cute on breasts. I'm a visual learner, so I happened to find a really great breast self-examination video done by the City of Hope. And I think that the physician that does this breast exam is most in line with what I recommend to my patients. So we're going to watch this together and hope that you learn from it and find it as important and interesting as I did. So can you just...
Hi, I'm Dr. Laura Cooper, one of the breast surgeons at City of Hope. Today I'm going to talk to you about self-breast examination. Around 8 out of 10 women detect breast cancers or breast lumps themselves. Therefore, it's important that every woman understand the basics of a self-breast examination. There are actually 2 components, look and feel. For the first part of the exam, looking, you want to stand or sit in front of a mirror. With your clothes off, you want to look at both breasts to see if there are any differences between the 2. Examine the nipples to see if there's any difference between the 2. Is one redder than the other? Is one pulling in? Then you want to put your hands on your hips and turn from side to side to see if there are any changes. While standing, you actually want to put your arms forward on your hips, because this will bring out lumps that might not appear otherwise. It's important to raise both arms above the head. This will draw out any puckering or dimpling for masses that might be underneath the nipple. If you're standing like this and you have a mass that's kind of in the lower part, you might not see it at all. But when you raise your arms, what happens is that mass kind of stays, and then the skin kind of pulls in as you're pulling up. That was the first part of the examination. For the second part, you want to be lying down. You want to put your head on a pillow to prop yourself up and place one arm behind your head. Then with your other hand, you want to or 2 fingers, you can actually separate the breast tissue and think that you feel something that isn't there. You can do this one of 2 ways. You can either go in a circular motion all the way around the breast, making sure that you overlap every area, or you can go up, down, all the way across. I prefer the circular motion from the collarbone to the sternum or mid-chest, below the breast, and then all the way actually out into the underarm. Lymph nodes are underneath the underarm, and sometimes those can become bigger. When you're doing the breast examination, you're looking for things that feel different from the surrounding tissue. What you're looking for is something that stands out, something that feels like a pea or a marble or a walnut. You want to make sure that you do this examination same time each month. Remember, the most important thing
Here,
about a
just
breast
stop it.
self-examination is to know your breast. That way you can note any changes and alert your doctor.
Okay, ladies, I apologize. I didn't realize that you wouldn't be able to see this video. So I'm going to send this along to Christina so that she can send it along to you. Again, my sincerest apologies. I thought this would be helpful for you. So in addition to breast self-awareness, what is important to continue doing is seeing your primary care provider or OBGYN or somebody who does a clinical breast examination as part of your examination annually to also check your breast tissue and kind of talk to you about any problems or concerns that you have. Okay. So genetic testing is something that many people are interested in who are at risk for developing breast cancer or have a family history. And if a person is interested in genetic testing, this is typically done in concert with a genetic counselor. At that first initial appointment, a family history is taken, a personal health history is taken, and a test panel of a number of different genes is selected based on that person's particular set of concerns. There are a number of different genes that are implicated in breast cancer beyond BRCA1 and BRCA2, which are the ones that most people think of immediately. So based on whatever panel is selected, either saliva or blood is obtained and then sent off to the laboratory. And then once the results come back, then the genetic counselor would talk to the patient about any mutations that are found and do counseling based on that. The results are interpreted based on that person's particular personal or family history, and then medical management options might be recommended based on that person's genetic testing, and that might help guide treatment. So one of my, for example, there is a gene that is a genetic mutation that can give somebody a higher risk for developing breast cancer that also gives you a higher risk for developing colon cancer. And let's say you're 38 years old and you find that you have this mutation. Well, typically you do not qualify for colonoscopy screenings until you hit the age of 45. However, if you have this gene, it might guide your healthcare team into maybe recommending routine colonoscopies a little bit sooner, knowing that you have this elevated risk. So that is one kind of example of why genetic testing might be useful. My little kind of spinning box over here talks about that about 1 in 10 breast cancers are hereditary. That means 9 out of 10 are not. But certainly if you are at an elevated risk and you have a strong family history, it is often very nice to know if there's kind of something going on in your genes that might put you at higher risk. There are treatments that we can do for people to help kind of mitigate that risk. And there's, again, additional screenings and different things that we can do as well. This is a very busy slide, but it is here for a reason. So the National Comprehensive Cancer Network gives guidance to clinicians by coming out with these guidelines on different ways to diagnose and treat and manage the care of people with cancer. We'll come back. Come back. And this is their most recent set of guidelines, recommendations for who really should consider genetic testing. And so they give this big long list, and these are the people who meet these criteria in my clinic that we talk in great deal about genetic testing. Does it mean you absolutely need to have genetic testing? Well, no. It's a very important decision that I recommend that people think very carefully about before they make that decision. But certainly these are the people that I suggest cancer, that they get genetic testing for cancer. Some people who do not meet this criteria also want genetic testing, and that's something, I never tell people that they can't have it, but this particular set of guidelines does help guide clinicians as to who would benefit most from genetic testing. Okay, so the next part of our conversation here tonight is about imaging. And the imaging that most people immediately think about when we talk about breast cancer screenings is mammography. This is the most common. We use X-ray imaging of breast tissue to identify abnormalities. Density, remember that term? Talked about it before, said we were going to talk about it again later. This can be a limiting factor in identifying abnormalities. Well, what does that mean? Well, density refers to the amount of tissue in the breast that is composed of like fibrous or thicker glandular tissue related to fat. The average woman has mostly, fat in their breast, but then interspersed with this fibroglandular tissue. The amount of each varies from person to person, and even over the course of a lifetime, you will sometimes have fattier breasts, and sometimes you will have more fibrous breasts, fibroglandular breasts. And so radiology has 4 different categories that they use to describe breast density on mammography, and they use similar ones in MRI. Category A is mostly fat. Category D is mostly dense breast tissue, and then B and C in between. B is more fat than dense, C is more dense than fat. And why this matters is because, as you see, that fatty tissue is very, very dark. I wonder if I can annotate here. If I took a little spot here that was white, you would be able to see right through it pretty well, right? And that's because it's that fat shows up very, very dark on mammography. So it's very easy to read composition A and look for abnormalities that way. Whereas you look at composition D, and it's very, very whited out in a lot of different places, and that is normal for this particular person's breast tissue. But because it does look like that, it can be a little bit more obscure in reading that mammogram. C and D also for the very same reasons. And there's some weird things about D, or this one here, that I'm not a big fan of. This particular breast in composition B, it does look like this woman probably needed to come back for further imaging, but it's easy to see those little whited out areas that are abnormal. Why? Because she's got a lot of fat in her breast. Ultrasound is another way that we look at, that we have to look at breasts. We use high energy sound waves, similar to if you ever had pregnancy. It's kind of a similar fashion. Okay, and then the next way that we can look at breast tissue is through MRI. It is the most sensitive of the 3 types of imaging available today. It uses a powerful magnet, contrast dye, radio waves, and a computer, and it takes very detailed pictures. MRI is often used as more of a diagnostic tool. If we find lumps or large lymph nodes on a breast exam, maybe that we didn't see on a mammogram, or if a mammogram or ultrasound was abnormal, an MRI might be recommended. In the high-risk breast clinic, we do use them as a screening tool if you are at high risk. But across the board, that's usually something that is kind of a higher tier choice for looking at breasts beyond that of a mammogram. So your imaging is abnormal. What happens next? So Typically, the imaging that you get on an annual basis is a screening mammogram or a screening ultrasound. The next step after a screening test is a diagnostic imaging test, and that usually shows a few more pictures or taken in a different way, and that helps kind of isolate, and get better views of maybe what might have been abnormal. A biopsy might be obtained of that abnormal area on imaging. Biopsies can be accomplished using mammogram, using ultrasound, or using MRI, and the decision of which route to go is decided by and performed by a radiologist. From there, if a biopsy is obtained, it is sent to a laboratory for evaluation and pathology. When you get a biopsy, a teeny tiny clip is inserted actually right into the spot where the biopsy was obtained. And that is done so that way, if it ever needs to be accessed again, they know exactly where to go. Or if it's normal, that little tiny clip is going to stay in your breast tissue for years to come. That way, if radiologist sees sees your same mammogram and it looks a little abnormal in that spot, they can see that clip and say, oh yeah, we already checked that. That is totally normal for this particular person. Further steps are determined based on the laboratory findings, the findings of that pathology. I like to include this slide because I like to give people a frame of reference. Less than 10% of women that are called back for more testing is found to have breast cancer. Okay, so it kind of helps to talk some people off the ledge a little that maybe are scared and nervous that they have to go back for additional tests. And I've been in that boat, so I know how that feels. Conversely, though, I do like to say 10% of women called back for more tests, there is something there that's important. So it's really important if you are called back for additional views of your breast that you go and get those done. Particularly in this pandemic world, some of this screening and testing and different things have kind of fallen by the wayside. So it's important if you have those outstanding tests that you do get your breast looked at. Okay, so over the past several years, decades, the treatment options in breast cancer have exploded. It's really exciting. There are a multitude of different ways that we can treat breast cancer and things that we know about breast cancer that we didn't know in years past, and ways that we can individualize treatment. To talk about different treatment options in breast cancer at length is a whole 30-minute talk in and of itself, and is definitely outside of the scope of today's talk. But I do want to say that your treatment options in breast cancer are carefully planned and by a multitude of different specialists, including a breast surgeon, a plastic surgeon that will aid in reconstruction if needed, medical oncology, and the different treatment options available are determined largely based on the type of cancer that is found, how far it's spread, and then also based on immunohistochemistry receptors, which is kind of a new and growing science where we're learning more about different targeted ways to actually hit your particular cancer. There are still surgical options available, radiation therapy following surgery, chemotherapy is an option. That immune-targeted therapy is new and exciting, hormonal therapy medications, as well as medications that not only treat but also reduce risk. So it's a really exciting world that we have, and different tools in our arsenal to help women and men fight breast cancer. So I gotta circle back to my favorite topic, which is prevention. It's always the best medicine. So remember those modifiable risk factors that we talked about earlier and do what you can to decrease them. Every little bit counts. Maintain a healthy weight. If you're holding on to some extra post-pandemic pounds, I'm guilty of that too. Try to shave off a few. Every little bit goes a long way. Increase your activity level, exercise. Avoid tobacco use. If you're going to consume alcohol, do so moderately or less. Breastfeed if you can. Consume a diet high in vegetables and lean protein. decreasing your consumption of fats and sugars. And if you have any concerns about any of these things, or you need somebody in your corner, talk to your healthcare provider. There's lots of different ways that we can help you in achieving these goals and helping you decrease these risk factors. If you have any breast concerns, please contact your OBGYN or primary care provider. That is the first step for identifying what's going on. And like I said, most women find their own issues. So it's important to, if something doesn't feel right, that they know about it. And if you're at high risk or increased risk for developing breast cancer, our high risk breast clinic team can help you closely monitor and be proactive about your health. And these are some of the references that I used in today's conversation. And I'll send over that link for the video so you can see it. It's a couple minutes of your time, but it's well worth the view. Okay. And again, I thank you so very much for your time. I'm going to send the floor over to Christina now.
All right. Thank you so much, Lauren. I'm going to stop this recording now. Once I stop it, that will open up if anybody wants to ask any questions. Now would be the time to do that.